I just wanted to talk very quickly today about this concept of accelerated long-term forgetting, or ALF. So this is a pattern of memory impairment that is distinct from the all-important rapid forgetting pattern that we've talked about previously. And it's a possible consequence of subclinical temporal lobe epileptic activity interfering with hippocampal memory consolidation. It's really important to be aware of because it represents a potentially very treatable memory problem. So to understand this a little bit more comprehensively, I draw your attention back to this schematic of memory processing in the brain that we've seen before, where in order to remember something, first you need to pay attention to the thing that you're trying to remember, you need to register the sensory information in the brain, then you need to encode it into a neural signature that can actually then be stored by the primary memory structures, and then importantly though, after you've stored it for the first time, there's an important phase of memory consolidation, particularly when you're asleep. And this is really crucial to stop you forgetting what you've just committed to memory, what you've just stored in memory, so that you can retrieve it efficiently later on. The issue in accelerated long-term forgetting is that there is a problem disrupting the consolidation phase. And that problem is in the form of epileptic discharges, particularly when you're asleep, interfering with the hippocampus. So just to understand this from a different angle, I have here a chart that represents the normal forgetting curve. This is sometimes referred to as the Ebbinghaus forgetting curve, although I haven't used that name here because the numbers on this graph are slightly different to what you might see when you look up the Ebbinghaus forgetting curve. But essentially the concept is the same. You learn some amount of information, and let's say you start at 100% after you learn it, and then as days go on, you slowly forget a proportion of that information. And so this is a graph of the percentage retention of information after you've learned it as a function of how many days since you last learned it. And this is presuming no spaced repetition, etc. In accelerated long-term forgetting, because there is disruption of the normal memory consolidation process, especially as you sleep, then that curve is just dramatically steeper. You get much more rapid forgetting with time, or rather you get accelerated long-term forgetting. And it's long-term in comparison to when you test memory confrontationally in the clinic, where you're testing long-term memory, strictly in the neuropsychological sense, but really usually only on the order of minutes to maybe half an hour, depending on the kind of testing that you're doing. So this is long-term compared to that, but there is clearly an abnormal accelerated rate of forgetting. This is just a nice schematic representing everything that we've just talked about, where, in the normal way of things, you have consolidation during sleep of premature memory traces that have only just been committed to memory. You have nice, rhythmic, normal, slow wave activity during sleep, so that a newly encoded experience is further processed and consolidated in sleep and then stored durably over time. Whereas in accelerated long-term forgetting, you have these temporal epileptiform discharges interfering with that process, disrupting processing and replay as you sleep. So consolidation is incomplete or disrupted, and so the resulting memory trace is much more poorly stabilized and fragile and more prone to forgetting. Now, identifying ALF in the clinic can actually be really challenging, and that's because confrontational testing may be unrevealing. Because it's really about an accelerated rate of forgetting over the period of days, if not longer than that. And longitudinal testing to try and assess a degree of forgetting over that time period is pretty impractical. One clue that you might get, though, is if you're able to demonstrate what's known as a temporal gradient. and this is also sometimes referred to as Ribot's law for describing retrograde amnesia. Now, this is the phenomenon whereby more recent memories are more disrupted than more distant memories, and is used in other contexts to describe how childhood memories or memories that have been consolidated over years and years are much more robust, whereas more recently formed memories are more fragile and more susceptible to being disrupted by some issue with the consolidation process. Now, the way that you might try and tease that out, whether there is a clear temporal gradient in a person, is by doing what's called an autobiographical memory index. Now, this is actually quite difficult to do and sort of usually needs a bit of a bespoke kind of assessment, but the general idea is that you would ask the patient to tell you about important milestones in their life and in world events with time since they were born, or perhaps since they were a teenager or something like that. And it's important to use both semantic information about world events as well as autobiographical information, but it's also important to ensure that the autobiographical information is corroborated by an informant so that you know if it's accurately recalled or not. And the idea is you might go through, half decade by half decade, and you might find that certain key things are remembered very, very well up until 10 years ago or something like that. That's demonstrating a temporal gradient, because all of a sudden the more recent events are suddenly not recalled very clearly. So say, for example, someone perhaps born in 1980, they might be able to tell you quite clearly things that happened all the way through the 90s, but then maybe you ask them, what happened on 9/11, and they can't tell you. That would be a striking example of a temporal gradient. In general, though, I think as a rough rule of thumb, one should be suspicious of the possibility of ALF, of accelerated long-term forgetting, if the history that someone's presenting with is strongly amnestic in character. There's a clear history of forgetting recent events or recent stories, or misplacing objects and so forth, but then on confrontational cognitive testing in the clinic, there's no significant memory impairment. And it's always worthwhile considering it because, again, it can be an eminently treatable memory problem. And if the rest of the clinical context were appropriate, and I had this suspicion, then I would certainly consider getting an EEG. And even if the EEG were normal, because of course there are limitations on the sensitivity for a routine EEG to detect subclinical temporal lobe epileptic discharges, then I would, in certain situations, even consider just empirically trialing anti-seizure medication to see if it improves the underlying amnestic problem. But the specifics of each situation need to be taken in measure. So there you have it. That's accelerated long-term forgetting, as distinct from the rapid forgetting that we more usually talk about. It's associated with subclinical temporal lobe epileptiform discharges, especially during sleep, disrupting the normal consolidation process, and represents a potentially imminently treatable memory impairment.